Okay, great. So good morning, everyone. My name is actually Mina Lamine, and I am the TB Control Team Lead at USAID Nigeria. I'll be presenting today on the identification of geospatial hotspots of TB HIV co-infection distribution in USAID PEPFAR-supported local government areas, or LGAs, in Nigeria. I want to first take this opportunity to acknowledge the many contributors to this abstract, both from our USAID Nigeria mission as well as colleagues in USAID Washington. To set the stage, I'd like to present some brief information about TB and HIV in Nigeria. As many of you know, Nigeria ranks 4th in the world and 1st in Africa of the 22 high-burden countries for tuberculosis. The WHO's Global TB Report 2016 indicated a TB prevalence of 322 per 100,000, or an estimated 586,000 incident cases a year. Approximately 180,000 TB-related deaths occur each year in the country. Nigeria also has the second largest burden of HIV infection globally, with an estimated 3.5 million people infected. The country has one of the lowest case detection rates among high TB burden countries, with just over 90,000, or 15% of the incident cases being reported each year. We believe low case detection is one of the primary drivers fueling the TB epidemic in Nigeria. From 1991 to 2001, there was a significant increase in the prevalence of HIV among TB patients, from 2.2% to 19.1%. However, the period 2010 to 2015 saw a decrease in prevalence from 25% to 17%, suggesting a downward trend in the TB-HIV co-infection rate. As far as we know, previous studies explored the spatial pattern of TB or HIV prevalence only, and in limited geographic areas, such as specific states within Nigeria. Studies examining spatial patterns across a substantial number of states, or LGAs, have not been conducted to date. So the hypothesis of this study is that there is a pattern of TB-HIV co-infection in select LGAs in Nigeria. Understanding this pattern could inform programmatic decision-making and potentially improve allocation of limited resources. There were two primary objectives of this study. One, to identify the spatial distribution pattern of TB-HIV co-infection among new and relapsed cases of TB, and two, to detect hotspots and areas to prioritize program resources towards control efforts in Nigeria. TB case reports for the period October 2015 to September 2016 were obtained from ART sites, or health centers, and the National TB Register. In total, 6,387 individual case reports were reviewed and analyzed. This data was from the 192 local government areas supported through PEPFAR and spread across Nigeria's 6 geographic regions: North Central, Northwest, Northeast, South-South, Southeast, and Southwest. HIV seropositivity rates among TB patients was calculated using data extracted from these case reports and national TB and HIV registers. Data on new and relapsed TB/HIV cases from 192 LGAs were then georeferenced. Two key spatial autocorrelation indices were used to detect patterns and clusters. The MORANS-1 tool measures spatial autocorrelation based on both feature locations and feature values simultaneously. Given a set of features and an associated attribute, it evaluates whether the pattern expressed is clustered, dispersed, or random. The expected value of MORANS-1 under a null hypothesis of no spatial autocorrelation, that is, negative values, indicate negative spatial autocorrelation, and the inverse is true for positive values. Values range from -1, indicating perfect dispersion, to +1, indicating perfect correlation. The hotspot analysis tool calculates the JEDIS-ORD GI star statistic for each feature in a data set. The resulting Z-score tells you where features with either high or low values cluster spatially. This tool works by looking at each feature within the context of neighboring features. For statistically significant positive Z-scores, the larger the Z-score is, the more intense the clustering of high values or hotspots. For statistically significant negative Z-scores, the smaller the Z-score is, the more intense the clustering of low values or cold spots. A feature with a high value is interesting, but may not be statistically significant hotspot. To be statistically significant hotspot, a feature will have a high value and be surrounded by other features with high values as well. So in terms of some of our results, of more than 16,000 case reports reviewed, 15,564, or 95% of new and relapsed TB patients had documented HIV status. Of these, 3,752 TB cases tested positive for HIV. This revealed that HIV seropositivity among TB cases was actually 24.1%, which is higher than the 2015 figure of 17% that I mentioned earlier. So this map shows the distribution of patients co-infected with TB and HIV by local government area, which is a sub-national unit. It's actually a unit that falls under each of the states of Nigeria, according to the data that was reviewed from the 192 LGAs. The darker blue color represents higher co-infection rates in a geographic area, while light blue indicates a co-infection rate of 0 to 9%. As you can see, there are several states such as Adamawa, Borno, Cross River, and the federally controlled territory, which have LGAs with high co-infection rates. The global spatial autocorrelation Moran's 1 statistics revealed a clustered distribution of TB-HIV co-infection. So given the z-score of 2.69%, there is actually less than a 1% likelihood that this clustered pattern could have been the result of random chance. Hotspot analysis indicated significant clusters of TB-HIV co-infection that were confined to LGAs in the Northeast, Northwest, Southeast, and South-South regions of the country. The pink and reddish colored areas represent hot spots, while the bluish colored areas are cold spots. Yellow areas are not significant. Again, from this map, you can see that certain LGAs within certain states like Adamawa, Borno, FCT, and Cross River have been identified as hotspots for TB-HIV co-infection. So, from this analysis, we concluded that the distribution of TB-HIV co-infection showed a non-homogeneous spatial distribution pattern. Some of the advanced analytical tools that we use could identify geographic areas with significant levels of disease prevalence patterns or clustering in order to prioritize TB-HIV control efforts. Use of GIS technology in disease mapping can inform interventions and strategic investments for epidemic control. As a next step, we are examining the causes and factors associated with observed patterns. USAID's implementing partners in Nigeria have also tailored their strategies and activities, particularly in identified hotspots. We see this as a first and novel step in improving our understanding of TB-HIV co-infection in Nigeria. Thank you. In full disclosure, I am not a GIS expert. I will have to say I'm representing on behalf of a team back in Nigeria, but I'm still happy to take questions.
Thank you very much. Any questions? If so, please come forward to the microphone.
So, my assumption would be that that co-location is based on where HIV is, but is there any, are there hotspots for TB, or is that more of a general distribution throughout the country?
So we were looking at TB-HIV co-infection specifically. There have been a limited number of studies that have been done to look at TB prevalence, and I think they are widely available. That is something that we're considering in the future, but since this was a study undertaken within our PEPFAR funded program, that's where we were focusing our attention.
Okay, so if it's okay, if the follow-up question is then, why are there hotspots of HIV within the country?
And so that's a very good question. One of the things that we're looking at now are the factors associated with those particular hotspots. Some of those LGAs in particular have higher population density, so it could be part of it that it's driven by numbers, and also neighboring LGAs that have service sites where we find patients are going. As I mentioned, the data was extrapolated from case reports. So one of the things our partners are now doing is actually better understanding what's driving these hotspots. Thank you for your question.
Very much. So we would like to introduce the next speaker, so that is patient education versus clinical management for increasing isoniazid preventive therapy. Thank you very much.
Hi, thanks for the opportunity to present this work on behalf of my colleagues at the Johns Hopkins Bloomberg School of Public Health and the Perinatal HIV Research Institute in South Africa. This is a figure that's published in the WHO report on IPT provision globally, and what we can see that while it started quite low for the first 4 or 5 years that they're showing here, there was a dramatic uptake increase, driven mainly by South Africa and also other African countries. But if you look at the y-axis, that's absolute numbers of people started on IPT per year, and we see that in the last couple of years it's peaked around about 1 million people. But if we think about what's the denominator, who are we trying to start on IPT, if you think about that as all new HIV infections, well, that puts us about halfway there. Now we know that all of those infected with HIV are not in care, but still thinking of something to aim for. But if you really think about the denominator as those who have HIV infection, there being about 37 million prevalent infections globally, I really would have to extend this way up or shrink the figure way down to make it all fit there, saying that we are really pretty far off the mark in terms of IPT provision globally. Why is this so poor? There's a number of reasons, and they're spread across the patient, provider, and also the health system level, which I'm not going to read all of these for you, but often we hear talked about that patients don't have good health literacy, that they don't adhere to treatment, providers don't see it as a priority, aren't trained, or are scared of creating resistance if they're treating someone with active TB. Then at the health system level, often there may be no support, no political buy-in, and there could be INH stockouts. So I'm going to focus today on these patient and provider areas for the intervention that we targeted. The overall aim of this study was to investigate whether strategies that are directed at the patient or the provider, whether they can increase IPT uptake in South Africa. So the study design had a pre-intervention period of 4 months as our sort of baseline, where we looked to see how clinics were doing. We then assigned half the clinics to a patient demand-building intervention and the other half to a clinician training and mentoring intervention. That lasted for 5 months, and then we withdrew the interventions from the clinics and had a post-intervention period to see what happened afterwards of 4 months. The patient education intervention were these short interactive presentations that were done twice daily in the patient waiting areas. In South Africa, it's common to wait 3 to 4 hours sometimes to receive care. These covered the basics of HIV and TB, as well as the purpose of IPT and the intended target groups. We had posters around the clinic encouraging patients to ask the nursing sister about IPT. We also had a printed calendar giveaway that we did during sort of question and answer period during the presentation. We tested all these components prior to the intervention in focus groups and used those to tweak the intervention a bit. The goal here was to encourage patients to request IPT at their clinical encounters. So here on the left, you can see part of the flip chart presentation that we did. These are 2 posters that we had up in the clinics. They were also translated into local languages as well, trying to encourage people and build a bit of demand for IPT. This is our counselor Mpo giving the talk to the patients in the waiting area. In terms of the clinician intervention, this was an intensive intervention focused on the nursing sisters at the clinics. The first week included a lecture on the guidelines, which we reinforced with role-playing, and had a group discussion of challenges at that particular clinic to IPT provision. The next couple of weeks saw peer-to-peer mentoring with our study nurse, where she went and had mentoring sessions during actual clinical care in order to understand the setting and understand individual barriers that the nurses were facing. Then we developed a group action plan to address specific barriers and elected an IPT champion at the clinic from among the nursing sisters who was going to support IPT at the clinic in the absence of our study nurse. Then the next couple of months, we supported the action plan. We did more peer-to-peer mentoring. And then in month 5, we supported by a text message. So the idea was to kind of draw out a bit of the clinic after we provided some intensive mentoring and training. So we conducted this study at 4 primary care clinics in Potchefstroom, South Africa, which is a mining area in South Africa. You can see it here on the map. It's about an hour south of Johannesburg. We randomized the clinics to receive either intervention, so there were 2 per arm. And the intervention period ran from October 2016 to February 2017, with 1 counselor educator per patient education clinic and 1 professional nurse for both clinician mentoring clinics. The primary outcome for the study was the proportion of HIV-positive patients per month who are prescribed IPT. In terms of some basic results, we managed to reach an average of 56 patients per patient education session per clinic per day. We had 2 quality improvement workshops per clinician intervention clinic, which was what we targeted. We had 9 mentoring sessions per clinician education clinic, which covered all of those nursing sisters who were providing IPT. And the average length of these mentoring sessions was about 84 minutes. So in terms of results, here in red we have the patient intervention clinics, and in blue the provider. And just obviously keep in mind the scale here on the y-axis only goes up to 15%. So the dotted lines here show our pre-intervention period during the first 4 months. Then we have our intervention period in solid lines over 5 months, and our post-intervention period. So what we saw during the pre-intervention period is that IPT uptake was tremendously low, right around between 1 and 2% in either arm. We bumped that up during the intervention period a bit. On average, it was 6.6% in the clinician education clinics, peaking at around close to 10, and then much lower, really not a negligible increase in the patient arm. And then after the intervention was complete during the post-intervention period, we saw those numbers come down as well in the clinician arm, and we still kind of flatlined in the patient arm. So just some perspective here, since I was talking about the scale of axes earlier. Looking at this at 100% scale, you can see that we managed to achieve just kind of a little bump in the clinician education arm, and really flatlined. And these really are quite low and not impressive numbers, as much as it pains me to say that about my own work. So in conclusion, the provider-directed intervention was more successful at increasing IPT uptake, but it didn't really result in meaningful gains whatsoever. And any gains that we saw weren't really sustainable after we withdrew the intervention. We did wonder if a combined intervention could provide a meaningful synergy, and that's something that we may look at in the future. And what we really saw were that the health system's barriers were what we really couldn't overcome. Believe it or not, even due to our modest increase in IPT at the clinician intervention clinics, that caused some IPT stockouts. So there really isn't a very good supply chain in place, and there was just a general lack of support at district and higher levels. And I just want to give a shout out to the qualitative work that we did. It's being presented in a poster. This is the qualitative work conducted with the nurses around the acceptability of our clinician intervention. So in conclusion, thank you very much to my collaborators and also my funding source, which was the CFAR at Johns Hopkins. Thank you.
Absolutely fascinating. And I see somebody coming forward for questions.
Luke Davis, Yale School of Public Health. Thanks, Colleen. That was a really nice presentation. My question kind of relates to your thinking about how these interventions should be designed. It seems like you guys identified sort of the lack of knowledge about IPT as a major barrier for both patients and clinicians, and it seemed like your intervention was quite an intense one in terms of addressing that, and that some of these opportunity barriers of stockouts and stuff were kind of the main barrier to doing that. I guess my question is, do you think the education intervention was effective, and would you recommend that that be included along with sort of other activities to address the stockouts?
The patient education?
Well, either of the education barriers. Did it seem like the lack of knowledge was sort of well addressed by your intervention, or do you feel that other interventions are sort of necessary to address the lack of knowledge?
Yeah, I mean, I think that our clinician education was successful at addressing a lack of knowledge. I think that we empowered the nurses with knowledge, but they were still bumping up against these health systems sort of level barriers where they just weren't encouraged, or it just wasn't a priority to provide IPT, and so and part of that can even be seen in the lack of M&E. There's been kind of a decrease in the amount of M&E that's done in South Africa for IPT. So if no one's really paying attention, if they're not looking at your numbers to see how you're doing, and if no one's encouraging you to do it from the top down, I think even empowering the nurses there just kind of led to very short-term, very modest gains. Yeah.
Thanks so much.
Hi, Harry Hausler, TB HIV Care and NPO in South Africa. Thanks, Colleen, for a great talk. And I just, further to what you've been talking about, the health system needing to support an intervention, I was wondering whether you involved the clinic managers, or what's called operational managers, in the training on IPT, and then also whether there was any kind of target setting. There is a district implementation planning process in South Africa, and sometimes, you know, if the district coordinators and the operational managers are on board, then they can help drive the process for implementation.
Yeah, we absolutely involved the clinic managers. They were part of the training. I think there was some recalcitrance on the part of one of our clinic managers who just didn't believe in IPT and just didn't see it as a priority. We tried to engage at the district level, and we just were not able to really generate much support from them or interest in what we were trying to do as far as training went, unfortunately. Yeah.
Okay, great. Thank you very much.
Good morning, ladies and gentlemen. I'm Unami Matebula. I'm going to be presenting improving sputum collection processes to increase tuberculosis case finding among HIV persons enrolling in HIV clinic and treatment in Botswana between 2012 and 2015. This is my outline, background, aim, methodology, result, discussion, limitations, and conclusion. Background. Undiagnosed TB or late diagnosis remains a leading cause of death among persons living with HIV in the middle and low-income countries, including Botswana. The Expect MTB assay has been an important tool in improving TB diagnosis. However, inadequate sputum collection among presumptive TB cases remains a challenge. The aim of the study was to investigate effectiveness of field effort to improve sputum collection among people living with HIV with TB symptoms under routine program conditions. Methodology. People living with HIV attending 22 clinics with access to Expect MTB were prospectively evaluated from August 2012 to October 2015. Patients were screened for TB using WHO symptom screening. If symptomatic, they were asked to provide sputum sample. For the first 10 months of implementation, that is from August 2012 to April 2013, That was our baseline. And after 10 months of the study implementation, that is from May 2013 to March 2014, that was our intervention phase. And during the intervention, the following were done: training and using of a sputum collection job aid, sputum induction procedures, monitoring using a sputum collection log. And then we analyzed the sputum collection rates and yield to TB diagnosis for baseline versus intervention. This our results. This table presents the characteristics of patient at baseline and intervention. We looked at the demographic characteristics like age and sex. We also looked at the clinical characteristics like previously on TB treatment and TB symptoms. Out of 2,851 patients who were enrolled and screened at baseline, and 3,190 who were enrolled and screened under intervention. These characteristics were similar for the two groups. This figure shows a timeline of sputum collection during baseline and intervention, that is from August 2012 to March 2014. The middle line indicates the time when the intervention started, that is March 2015. This table indicates the sputum collection and TB diagnosis among presumptive TB during baseline and intervention. The characteristics that we looked into were presumptive TB cases, sputum collected, samples submitted more than one, and TB diagnosis. On this table, we can see that when we compare the baseline and intervention for presumptive TB cases, there were no difference as it was 30.5% to 31.1%. But when it comes to sputum collection, we can see it's increasing from 41.7% to 58.3%, with an increase rate of 87%. And then when we look at the TB diagnosis, we can also see that it increased from 5.1% to 9.2%. That is almost double of the baseline numbers. This next table is on sputum characteristics during baseline and intervention. We looked at whether the sputum was salivary, mucoid, or mucopurulent. We also looked at the volume of the sputum collected. We can see that the salivary sputum decreased from 34.4% to 26.1%, which was good since salivary sputum doesn't give much. Mucoid and mucopurulent result sputum increased from 9.6 to 15.9% and 49.1 to 55% respectively. The volume also increased with an odd ratio of 1.28 from a percentage of 68% to 74%. The discussion, we have covered a lot of a discussion when I was presenting the result slides. I'll go on to the limitations. The limitations, like all studies, our study had some limitations. This evaluation did not measure the separate impact of intervention improved sputum collection. It was conducted within the context of a structured field evaluation and may not fully reflect pragmatic conditions. Conclusion. Our findings indicate that a field intervention improved sputum collection rates, quality of sputum, and intensified TB case finding among presumptive TB cases. However, even with intervention, sputum collection rates were still low. Further evaluation on sputum collection improvement is essential to optimize the use of expect for case finding among people living with HIV. Thank you.
Thank you very much. I think even though you're saying it didn't increase sputum collection rates very much, I think it is very impressive results that you doubled your yield. And I wonder, if I may ask the first question, did you actually also double the people starting on treatment, or did people who didn't manage to provide sputum might have been started on clinical grounds anyway? So did you actually see an impact on treatment initiation?
All the patients that we diagnosed on TB, with TB, we made sure they went on to TB treatment. Thank you.
And I had if I could see the numbers correctly, 30% of your patients were women, is that right? So 70 were men? I was just wondering, what is the setting, knowing that, we struggle in a lot of countries getting men to access services routinely? Or did I misread that because it was so small from here?
Can we go back to that slide?
So I guess the question is, what is the setting? You said they're primary healthcare clinics that offer, I guess, chronic disease services?
What?
32% female, right? So the majority were male in your facility? I just, in Lesotho, we're really struggling to get men into facilities, and it's largely about the opposite in terms of male to female ratio. So I'm just wondering the setting.
Could you come up with a question again?
Your facilities, what type of facilities are these that you looked at?
Outpatient clinics.
Outpatient.
Yes.
Thank you very much.
Okay.
So we would like to ask the next speaker, H. Hong, substantial increase in the risk of HIV patients with multi-drug resistant tuberculosis for aminoglycoside-induced hearing loss. Thank you very much.
Hello everyone, my name is Hye Jung Hong. I'm a nurse practitioner and a PhD candidate at the Johns Hopkins University School of Nursing. And today I'd like to introduce my one of my meta-analysis outcomes titled Substantial Increase in Risk for HIV Patients with MDR-TB for Aminoglycoside-Induced Hearing Loss. As you all know, ototoxicity is a really common adverse drug reactions from aminoglycoside treatment, especially is caused by permanent hair cell damage in the ear, and also the symptoms begin with the high frequency hearing loss. That's why early detection is pretty much hard in the clinical settings. And the symptom hearing loss causes the patient's social isolation, which will worsen the patient's quality of life even after the treatment. Even though we already know it is ototoxic, but the aminoglycoside, including kanamycin, amikacin, and or streptomycin, is still a mainstay of MDR-TB treatment because it is comparably cheaper and highly potent. From literature review, we found that the risk of hearing loss is higher in low-income and HIV endemic countries. For example, in the United States, the incidence of hearing loss is about 13%, and in the European countries and in India, even though it varies, is in between 18 to 28%. However, in Sub-Saharan Africa, guess what? It is really high. It is in between 23 and 69%, really high. Why? Why Sub-Saharan Africa has higher risk of hearing loss? We try to find the answers from the adverse outcome pathway model. If patient has been diagnosed with the MDR-TB in these settings, a lot of patients are allocated to the aminoglycoside injectable treatment. From the almost daily injectable treatment and then the medication molecules will be accumulated in the inner ear hair cells, which will be accelerated by the poor kidney function of the patients. And also the cumulative medications will formulate more free radicals, which will cause apoptotic hair cell death in the inner ear. So finally, the patients will experience some level-based hearing loss during the treatment. If a patient is HIV co-infected and living in a resource-limited settings, then they are more likely to be exposed to liver toxic or kidney toxic medications to treat HIV or some other different type of opportunistic infections, which will directly or indirectly related to the risk of hearing loss. And also, a lot of patients in these settings are malnourished, and not only because of the resources, but also for the diagnosis of TB. The low body weight at the beginning of treatment may be directly related to the drug accumulation because the aminoglycoside is limited by the kidneys. And also in these settings, frequent hearing tests or any type of drug toxicity monitoring is not really sufficient or impractical. So all these risk factors may be related to the increased risk of hearing loss. So the main purpose of the study is to evaluate the existing evidence for the risk of HIV co-infection on aminoglycoside-induced hearing loss among MDR-TB infected individuals in sub-Saharan Africa. So we use a lot of search engines and manual search with librarians by using the search terms of hearing loss, aminoglycoside, and sub-Saharan Africa. And we included articles having the participants with confirmed or suspected MDR-TB and received second-line injectable TB treatment, including kanamycin, amikacin, streptomycin, and caprimycin. And we also include all ages and genders. To be included, the study has to be conducted in sub-Saharan Africa and reported in English. And if the study is published before 2000, or they use the aminoglycoside not for MDR-TB treatment, then we exclude it. The final analysis for meta-analysis has been conducted with the state of version 14. As you can see here, we use a PRISMA flow chart to evaluate what would be the eligible for the meta-analysis. The initial search gave us about 368 articles. This is a really small number. And finally, we include 8 studies into the analysis. Because each study used their own definitions of hearing loss, we included 3 different levels of hearing loss in the analysis. First, audiometric hearing loss, which means any worsening of hearing threshold confirmed by audiometry, either standard audio booth or portable computer-based audiometer, with or without use of tympanometry, has been accepted. And patient self-reported hearing loss was also accepted into the analysis. And lastly, the clinician-identified hearing loss means any diagnosis from the clinical evaluation without using audiometry evaluation was also accepted. Again, finally, we included 8 studies into the analysis, and mostly they are targeting to adult populations, but one study actually sampled the children population. And all the studies observed the outcome of hearing loss prospectively or retrospectively, and half of the study were conducted in South Africa, 2 in Botswana, and 2 in Namibia. And 3 studies actually used the conservative definition of hearing loss using the audiometry. But about half of the studies used the composite definition of hearing loss using either audiometric or clinician-identified hearing loss. The prevalence of HIV ranges from 30 to 83%, and the cumulative incidence of hearing loss in the study settings pretty much varied. It ranged from 23 to 69%. And we use the cumulative incidence ratio, in other words, relative risk or risk ratios, as a pooled measure of association by using the Mann-Hansel fixed effect model because we found some homogeneity between studies. This is our final findings. As you can see in the middle column, both kanamycin and amikacin top two choice of the aminoglycoside from across the 8 study settings, even though one study didn't specify the type of medications. The pooled relative risk is 1.22, which is statistically significant. In other words, if a patient has HIV co-infection at the beginning of MDR-TB treatment, their risk of hearing loss during the treatment is about 22% higher compared to HIV-negative individuals in these settings. And also, we wanted to test the effect of ERT status at the baseline, but unfortunately, those 2 studies reported the participants' ERT status, and there's completely no agreement at all. So these slides tells me definitely we have to conduct further studies, including a lot of HIV-associated variables to check or to test any impact of a HIV infection on the hearing loss. So finally, we concluded that MDR-TB and HIV co-infected individuals had 22% higher risk of aminoglycoside-induced hearing loss compared to HIV-negative individuals in these settings. This is the very first meta-analysis, not to knowledge, even though we use very small sample size, and it is impossible to control some of the potential confounders such as age or any use of ototoxic or nephrotoxic medication during the treatment. However, the study findings actually lend some credibility to HIV co-infected individuals into injectable sparing regimens, for example, bedaquiline, and or more frequent hearing monitoring or any other drug toxicity monitoring or testing, and especially in resource-limited settings like Sub-Saharan Africa. Thank you very much. Any questions?
Thank you very much. Any questions? Well, then I think in the interest of time, we are going to move on. Thank you very much.
I don't know why this doesn't work all the time, but if we have time at the end of the session, we'll allow for a couple extra questions. So we're going to move from Kenya to Botswana, talking again about treatment outcomes, and hopefully they're not as dire. Dr. Agazu, please come forward.
Hello, good afternoon, everyone. Thank you for inviting us to present. Yes, I'll be talking my presentation from Botswana as well. And I'll be talking about, as a wrong slide, I guess. It should not count my time on this. Okay, I'm going to present from CDC Botswana as well. And what I will be talking about will be actually the same data coming from where Ms. Matebula was talking about. So most of our slides will be very, very similar. But trust me, I have not copied anything from her. It's only that the same person supervised the slides. So can I have my slide, please? Good, thank you. Okay, so I will be talking about the treatment outcome among people living with HIV with non-tuberculous mycobacteria versus Mycobacterium tuberculosis in Botswana. Next slide, please.
Oh, you can also see it down there.
I'm sorry, very sorry.
No, it's not obvious. And then this is the one.
Good, sorry for my confusion. Okay, the outline of the presentation is background, aim, methods, results, and conclusions. So as a background, patients with non-tuberculous mycobacteria, NTM and Mycobacterium tuberculosis pulmonary disease may have similar clinical presentations. And where testing capacity for expert MTB or culture or NTM speciation is limited, there may be a misdiagnosis for NTM and suboptimal treatment as well as suboptimal treatment outcome. So the aim of the study was to describe the outcome of TB treatment outcome among presumptive TB patients with culture-positive NTM and MTBC who received anti-TB treatment. So methods, patients living with HIV, attending the 22 HIV clinics were screened, enrolled and screened. Those who screened positive for more than one TB symptom were asked to submit sputum. And clinical information and lab information were analyzed, and TB treatment outcome and characteristics of patients for NTM and MTB were compared. And unfavorable outcome in this study was defined per WHO, like died, failed, or lost to follow-up were unfavorable outcome, and cured and completed were a favorable outcome. So results. In this study, this is a sub-study from a big clinical trial where we have enrolled more than 16,000 patients, 6,000 prospectively and about 10,000 retrospectively. And from these patients, 402 culture positive were there, and 174 were positive for MTBC, and 228, which is 57%, were NTM. And of which 36 patients, which is 16%, received TB treatment, and all patients with culture positive for MTB also received anti-TB treatment. And in the NTM group, 4 patients out of 32 with complete treatment outcome were having unfavorable outcome versus 12 out of 138 with available treatment outcome, which is 8.6% for patients with culture positive for MTB. So this is characteristics of patients with a positive culture for NTM and MTB treated with anti-TB treatment. You may wonder that why patients were treated for TB while they were NTM. The reason is clinicians started these 36 patients of NTM who were culture positive and received TB empirically. And when the result was available with a negative culture for MTBC, they decided to continue to finish TB treatment. That's why they received the treatment. So when we compare the patients receiving TB treatment among NTM and MTBC group, the characteristics were similar, for age, gender, CD4, and symptoms of TB and the like, except, the AFB positivity, which is understandably higher among patients with MTB positive, and that was the only difference. So this is, I think, the heart of my presentation, so to say. So the treatment outcome among patients with living HIV with positive culture for MTB and NTM. And as you can see, there were 32 patients among NTM group who were treated and to whom we know the treatment outcome. And there were 138 patients among patients with MTBC. So 4 patients had treatment outcome which was unfavorable, which is 12.5% in the NTM group versus 8.7% for MTBC group. And the difference similar, but the study was not designed to answer these things. So I wouldn't say, the study was as such, have enough power to tell us about it. But from the finding we have so far, although a bit high, the unfavorable treatment outcome under NTM, but the difference was not significant. So we also wanted to see what is the risk factor for patients being treated for NTM when the culture was negative for MTBC. So when we compared, the difference was patients with low BMI and weight loss, and patients who history of TB. I have a glass problem, so yeah, patients who had previous TB actually were more likely to receive treatment, anti-TB treatment, compared to the 2 groups. So in conclusion, though the treatment outcome was similar, our study was able to find, the risk factor for receiving anti-TB treatment among the NTM group. So patients with weight loss and previous TB were likely to receive more anti-TB treatment compared to MTBC. And then we need further study to characterize further such happenings. Thank you very much.
Thank you very much. I think, we kind of underappreciate NTMs very often. Can I just ask, do you have any idea what species these NTMs were? And my other question, just because I have trouble seeing that far, what was the amount of smear positivity among those which then ended up having an NTM positive culture? Because if the only diagnostic you have is essentially a smear microscopy, then those patients would all be kind of labeled as smear positive disease despite actually having NTM disease.
To start the first one, we speciated almost all NTMs, and more than 50% of them were actually intracellular. But there was about 8% of the NTMs were clinically significant actually from our speciation. About the AFB smear positivity, I think this slide can show that we have 7 patients in each group having smear positive. But since the NTM patients were 36, I think the proportion was, can't see it properly, 19% versus above 50% smear positivity. Next time I will have a better glass, I guess.
So the only NTM that I can think of that would really respond to tuberculosis therapy would be Mycobacterium kansasii, possibly. And so I find this success rate of your NTM to be very surprisingly high. Can you explain that?
Come again, sorry, I don't think if I get your question.
So most non-tuberculous mycobacteria will not respond to tuberculosis therapy, as far as I know, except for Mycobacterium kansasii. So supposing that not all of your NTMs were kansasii, and so I find your success rate actually very high for non-tuberculous mycobacteria. Did you think about that when you were analyzing your data?
Yes, I think the kansas in our group was maybe 1 or 2 of the over 200 NTM were kansasi. And I did not say, by the way, NTM responded for anti-TB treatment. That's not what I said. What I said is among patients treated, some of them obviously, since it was not TB, even if you treat it, obviously patients will get better because it was not TB, and treatment of TB doesn't change it anyway. So maybe we'll have further, things to see to answer your things, but I'm sure we'll need further study, around this problem.
Sorry, can I just follow up on that? Isn't it a question of what you define as failure? So what you say is unsuccessful treatment was essentially people who either died, or what was your definition of unsuccessful treatment? Because it's not really culture conversion, or have you looked for culture conversion?
Yeah, the definition of unfavorable outcome, or if you call it unsuccessful, is patients who died, failed, or lost to follow-up. So my belief is this is kind of an eye-opener to us that, it needs further study, actually, this kind of problem. Because in the era of expert is not showing, by the way, any patient-level treatment outcome compared to smear. This might be one of the reasons why we are not seeing, because patients are unduly treated, with TB treatment when they were not supposed to, and thus we don't see the difference between these two groups.
Yeah, no, so I think, your unsuccessful outcome is basically a very coarse outcome. And the people you didn't start on treatment might have, if you looked at their symptoms, with or without TB treatment, if they had NTM disease, they might have just continued being symptomatic and not improving. But it's not that it rapidly leads to death.
Yes, possible. One more question.
I'm Dr. C.K. Chen from Hong Kong. Just a follow-up question on the relatively high treatment success rate for the NTM infection. Just wonder whether some of the patients diagnosed to have NTM disease might indeed have radiological tuberculosis and NTM colonization. Is that a possibility? Because as mentioned, usually only the M. canceri will
I don't
have.
think we get your question. Can you say it clearly and loudly so that we get it?
Okay, yeah. I have a follow-up question on the relatively high treatment success rate for the NTM disease. Because as mentioned, most of the time the NTM disease will not respond so well to anti-TB drugs. Just wonder whether some of the patients might indeed have radiological tuberculosis with NTM colonization rather than NTM disease.
Yeah, what I would say is, again, I wouldn't qualify it as such treatment success. I only compared it so that we know where the unfavorable outcome is coming from when we treat, or rather, to justify, why we are not seeing a better outcome comparing expert with smear. That was, more, informative, from what I'm saying, but I wouldn't necessarily, interpret it that, this is a treatment outcome for NTM when they are treated with TB. I wouldn't say that. In the first place, they were not supposed to be treated. Secondly, TB, as you have said already, some of them may partially respond, and thus, you might see the difference as, improvement or cured. But that doesn't qualify really as a proper treatment for NTM.
Okay, great. I think we're going to have to thank you there, and we can take this offline. There's a lot of interest in this discussion. So thank you again. We'll call our next speaker. Our eighth and final speaker comes from South Africa, talking about urinary LAM in an outpatient setting. Our Kubiak.
I'm Rachel Kubiak from the University of Washington, presenting on data from our partners in South Africa. So as you've as you've heard, tuberculosis is the leading cause of death among people living with HIV and a major source of morbidity. The WHO recommends that in these high HIV burden settings, people infected with HIV be regularly screened for TB, using their TB symptoms, and if they test positive, be treated. If they screen positive, be tested using a molecular test such as GeneXpert. Among those with HIV infection, extrapulmonary disease is also more common and requires culture to confirm diagnosis. Our existing diagnostic options all have serious limitations, such as the time to positivity, the requirement of laboratory facilities, the collection of sputum, and potential aerosolization of the mycobacterium. So we lack a rapid and easy-to-use diagnostic test that can prognosticate outcomes, allowing clinicians to identify those patients most at risk of death. The urine LAM lateral flow assay may fill a gap in the field of TB diagnostics. The assay is the strip on the right, and it's dipped into a cup of urine, and the color of the line that appears is matched to a card that is provided by the manufacturer. In our study, we used a card that ranged with 0 for negative and 1 through 5 for positive. The cost of the test is low. It is simple to use at the point of care, requires only 25 minutes for a positive result. However, in the general population, it has a low sensitivity of around 30 to 50%. A previous analysis of this cohort found the sensitivity in this population was 31%. So incorporation of the urine LAM assay into diagnostic algorithms has been slow. Because of the strengths of urine LAM assay, it's important that we explore all the potential uses of the test and fully understand how the information it offers may contribute to clinical treatment and outcomes. Specifically, how the urine LAM assay may be a potential marker of disease severity and associated with mortality. So we hypothesized that among newly diagnosed patients with HIV and tuberculosis disease, urine LAM positivity is associated with increased mycobacterial burden, increased disease severity as measured by TB symptoms and vital signs, and mortality over 1 year of follow-up. We used data from the completed Cisnani randomized controlled trial that investigated the impact of a health system navigator intervention. Our study population was comprised of HIV-positive adults at 4 outpatient clinics in Durban, South Africa. All participants were screened for TB using the WHO symptom screen. Sputum was collected for AFB smear microscopy, liquid and solid cultures, and urine for the rapid urine LAM assay. The lab technician who processed the sputum and performed the smear was blinded to the urine LAM assay results. We followed participants for 12 months and used clinical records and the South African National Death Registry to determine survival status. So we considered a person to be positive for TB if they had at least one of the following: an AFB positive smear, a positive solid culture, or liquid culture. In these analyses, we included only those who tested positive for HIV and TB and who had a urine LAM test result, which was introduced partway into the study. This took us from the original 1,900 enrolled to the 726 who had a urine LAM test, to the 139 who were smear or culture positive. And urine LAM was considered positive if they tested at least 1+. In this table, we compare the demographic and clinical characteristics of our patient population, and we see that they are similar in terms of age and gender. The people who are LAM negative were less likely to have completed high school, less likely to smoke, had a higher heart rate, lower mean arterial pressure, and lower CD4 counts. They did not differ by TB symptoms or smear. LAM positivity was not related to liquid culture positivity, but significantly associated with solid culture positivity. So you can see here we see the solid culture positivity, and you can see that nearly double the proportion of LAM positive TB patients were solid culture positive as compared to LAM negative TB patients. And we also found that those who were LAM positive were more likely to die over the course of the 12 months of the study, with, again, 37%, nearly double, 37% of the population who were LAM positive dying over the first 12 months compared to 14%. So this figure just confirms the lack of relationship to liquid culture positive. You can see that there's no difference between the LAM negative and LAM positive groups in terms of their time to positive culture. And here we used a adjusted multivariate logistic regression, adjusting for the variables that you see here to look at the factors associated with LAM positivity. And we found a persistent association with solid culture positivity, as well as elevated heart rate. And here we can see the time to solid culture, or time to death over the course of the study. We see that urine LAM positivity, the red line, is associated with a shorter time to death by the end of follow-up. We found the risk of death increased more than 2-fold for TB HIV patients with a positive LAM result after adjusting for age, gender, education level, smoking status, and CD4 count. Of note, the majority of these deaths occur within the first 3 months of the baseline visit, whereas only 12% of the LAM negative patients died within the first 3 months. During this time, treatment initiation was likely delayed as some patients waited for the results of their diagnostic tests. So to summarize, we found that urine LAM positivity was persistently associated with solid culture positivity, but no association was observed with liquid culture positivity. We believe that solid culture positivity may be a marker of morbidity and higher mycobacterial load, since it's a less sensitive test. We found no observable difference in TB symptoms, with the exception of an elevated heart rate for vital signs. And most importantly, we found an over 2-fold mortality increase over 1 year, with most deaths occurring within the first 3 months of TB and HIV diagnosis. So to conclude, we found that it's associated with limited features of morbidity, that it is associated with solid culture positivity, and most importantly, it's associated with an increased risk of death. So we think that despite the limited sensitivity of this test, it may be useful at rapidly identifying outpatients with the highest risk of death and getting them on treatment faster. So I'd like to thank all of our partners.
Excellent. Anybody have any questions? Please go to the mic while you're walking there. I sort of, because it's really hard to see from here. Did you look at CD4 counts? And who the inclusion criteria was under 100, is that correct or no?
We looked at CD4 counts in a lot of ways. CD4 count was associated in unadjusted analyses with LAM positivity, but not after adjustment for most anything. They had lower CD4 counts as you'd expect. And I didn't present it here, but we looked at patients with low CD4 counts only and found a persistent association with death. I'm actually talking about that tomorrow.
Great. We have 2 other questions here. Please introduce yourself.
Luke Davis, Yale School of Public Health. Thank you. Very interesting, very important work. You suggest that there might be an opportunity to modify this mortality in patients who have a positive LAM or higher grade LAM. And I was wondering if you saw a delay in treatment initiation among those who are LAM positive, or if you think there might be other types of interventions to follow these patients more closely during the first 2 months to decrease mortality.
That's a great question. I have not had the opportunity yet to look at the time that treatment was started, so but that's a really important question, and hopefully it'll show that they started later.
Thanks.
Yeah.
Morning, hi, so thanks, very nice presentation. Sanj Karat from the London School of Hygiene. I just had a point of clarification. Earlier in your presentation, you said LAM was recommended for screening in people with CD4s of less than 100. And my understanding, and maybe this has changed, is that it's actually recommended for diagnosis and not for screening. But based on the data that you've shown, would you say it should be extended to also screen people for TB, rather than necessarily identifying people with TB at high risk of death?
Yeah, I think it is recommended for screening and diagnosis of TB, and that we've seen data from hospitalized settings that show that it seems to impact treatment success and a lower mortality rate. And so this data from an outpatient setting among the general population, and we're actually talking about the TB negative population as well. Tomorrow, this was only people who tested positive for TB and found, well, I don't know if I should say this yet, but it seems to be a good test for everybody at prognosticating death. And so we think that it could be useful everywhere.
Hi, Tom Boyles from, currently from WITS, actually. I think this is fascinating. I mean, in general, LAM in an outpatient setting has been a failure. Many studies over the years have shown it to be a failure, and yet what you've shown really mimics what we see in the non-ambulant patients, which is, this is a good predictor of mortality. So it's kind of incongruous to find this result, and which is why I find it so interesting. And what I'm really interested in is how sick were these patients? Like, were these patients, what were the inclusion criteria into this larger study? I'm not familiar with it, because it seems like you've got patients who are really pretty unwell, maybe close to, were they patients who were kind of close to requiring admission? Are they much closer to that non-ambulatory group where we know LAM is so successful, compared to the ambulatory group where we know in general it's been very unsuccessful? I just find it very interesting. I wonder if you could comment on that.
Yeah, that's a good question. This data is from, I think, 2012 to 2015. So people were a little bit sicker coming into the clinic then than I think they are today. The median CD4 count was 205. So people were pretty sick. However, there were a lot of, the interquartile range for CD4 count was almost the same. So there's a big range of health in this cohort, with the average being a relatively sick person.
Please make it brief. We're a little bit over time, or we can take it offline. No, go ahead. Go ahead.
Okay. All right. I'm Dean Tsukayama from Minneapolis. I was just wondering, if you treat patients and they start to get better, does the LAM test change over time? And if it stays positive, is that even a worse predictor of somebody's mortality?
We did not do LAM testing over time, and I don't know how it would predict mortality, but it should become positive as people have less mycobacterium in their system. Or it should become negative as people have less mycobacterium, but I'm not sure how that relates to mortality.
Great, thank you very much. A lot of interest. So let's give all of the speakers a round of applause for these great presentations, going from geospatial mapping to LAM. I do want to thank you all for coming, and I also want to remind you all, we have our HIV section meeting this evening at 5:45 in the room Los Arcos. So I really encourage you all to join. Many of us will be there.